Good morning, everybody, and welcome to today's presentation. Today's speaker is Dr. Vanessa Ramatshela. She's an experienced emergency medicine practitioner or doctor who has a passion for her specialty that began in a community service here in Witbank Hospital. She commenced her registrar training with the Wit Circuit in 2014 before transferring to the University of Pretoria in 2017. She's currently completing her MMed. With a deep dedication to acute trauma care, she firmly believes in the importance of the golden hour in improving patient outcomes. Today, she will be discussing the evolution of trauma management, specifically the shift from the deadly triad to the deadly diamond of death. Thank you. Sounds very exciting.
Looking forward.
Okay, so good morning. This morning I'll be presenting the lethal diamond of death in trauma. We have currently shifted from the triad of trauma, so I'll just go into it as we go on. Okay, so let's first start with what we all remember as the golden hour. That death occurs quite rapidly within the first 2 to 6 hours after the injury, and this occurs from the hemorrhagic shock that the patient experiences. So we need to intervene quite urgently with our resuscitative efforts by combining hemostatic interventions and timely blood product administration. So the original triad of death included the hypothermia, the acidosis, and the coagulopathy. When a patient has been injured, the first thing that they do, they bleed. Okay, and as they bleed, they lose fluid, and that results in hypoperfusion of cells. That will then result in acidosis. And bleeding also results in coagulopathy because, as you know, our patients not only bleed water, they bleed blood and blood products as well. And that also impacts the clotting factors in the patient. As a patient is also exposed to environmental temperature, it also results in hypothermia as well. So it's quite important for us to intervene and prevent this, as this will worsen the outcome of the patient. So what is it about the calcium that they have added? Why do we need to consider the calcium? With a constellation of physiological derangements, it has contributed that the hypocalcemia results in ongoing hemorrhagic shock, which then leads to an increase in mortality. So along with the hemorrhagic control that we do, we need to give blood products in an effort to reverse the hemorrhagic shock. And as a result, we activate what we call a massive transfusion protocol. Massive transfusion protocol comes with complications. So it will result in electrolyte derangements, which also include hypocalcemia. And studies have shown that over half of our trauma patients are already hypocalcemic. So we need to be very vigilant when it comes to correcting our calcium level in our patients. It has also been shown that hypocalcemia contributes to coagulopathy, which then leads to a continued blood loss and possibly death. What's the pathophysiology of our calcium? Calcium is quite important in the body function as it helps with the coagulation, it helps with platelet adhesion, and it also helps with the contractility of the myocardial and smooth muscle cells. We need it to help with the clotting factors of factor 2, 7, 9, and 10, and protein C and S for the activation of the damaged epithelium. It also aids in stabilizing the fibrinogen and the platelets for thrombus formation. Any ionized calcium level below 0.8 and 0.9 millimoles per liter will lead to worsening of the coagulopathy and impaired vascular dysfunction. Calcium is also important as it assists with the cardiac contractility, as we remember from our cardiac cycle. And it also helps with the vasculature constriction and dilatation. When we bleed, we lose the calcium. And as a result, hemostasis is disrupted, and the citrate used to preserve the blood is also reduced. So in other words, we need the calcium when we bleed, but when we bleed, we also lose the calcium. So what is the mechanism of hypocalcemia in trauma? It has been shown that 97% of our patients who receive massive transfusion protocol during trauma resuscitation are hypocalcemic. And of that 97, 71% of them are severely hypocalcemic. And this leads to a 49% in mortality. Blood products are stored in an anticoagulant citrate, and this doesn't help us as a result because the calcium then binds to the citrate, which then reduces the ionized calcium level in the blood products that we need. So as a result, there's just a vicious cycle when it comes to the hypocalcemia and our outcome of our patients. Our trauma patients, remember, they also have comorbidities, and some of them will present with liver disease, and that will also further reduce the citrate metabolism. So what's the moral of the story? So low calcium basically reduces your cardiac contractility, it reduces your vasoconstriction, it prolongs the QT interval, which then predisposes your patients to have dysrhythmias. It decreases the effectiveness of coagulation panel, your clot strength, and your platelet binding. And as a result, it worsens the acidosis. So calcium in coagulopathy. When you are hypocalcemic, your clots form less, or the clots that are formed are weaker. So how do you approach this? Make sure that you stop the bleeding, give the blood early with the calcium, limit your crystalloid infusion, as it also dilutes your clotting factors, and remember the tranexamic acid in the first 3 hours from the time of injury. Hypocalcemia also worsens your acidosis and hypoperfusion as it increases cardiac contractility and your vasoconstriction. Hypothermia results in hypocalcemia, so also remember to keep the patient warm and give warm fluids. So what is the lethal diamond in a nutshell? The lethal diamond now consists of the hypothermia, whereby you see that the hypothermia causes a decrease in liver metabolism of the citrate and is not metabolized in the liver, therefore your calcium is not bound. You also have a coagulopathy, where the calcium in the plasma is a necessary cofactor for clotting. You have acidosis, which also lowers the pH of the hypocalcemia, and the lower pH prolongs your clot formation and the hypocalcemia as well. So what proof do we have that hypocalcemia results in all of this? So there was a meta-analysis that was done that found that 56% of patients with severe trauma resulting in hypertension have hypocalcemia. It therefore resulted in an increased mortality, an increased need for blood product transfusion, and an increased risk of coagulopathy. So the studies are not quite strong because there's no randomized control trial that was done, but there were multiple retrospective studies and observational studies that were done. And one of these was a review of the transfusion and trauma-induced hypocalcemia, which reviewed 3 major articles, and it found that the hypocalcemia does result in a worse outcome for our patient in trauma. Another systematic review that was done, was done recently in 2021, and this is the one that we base our management of the patient. Okay, so this is just a repeat of the slide that I mentioned earlier. So what options do we have with regards to managing the patients in the emergency unit? So the option is that every patient that comes to you, when you're going to start packed red cells on the patient, give 2 grams of calcium gluconate every 2 to 4 units of the packed red cells. And then check your ionized calcium every 1 to 2 hours. The debate now is which one is a bit better between calcium gluconate and calcium chloride. We know that the calcium chloride has got a higher content of elemental calcium, but it has been found that the doses should not differ with regards to whether you're giving the calcium chloride or calcium gluconate. It's just that you need a bigger line for the pain when you give the calcium chloride. Okay, so just an interesting case so that we can put everything together. I've got a 24-year-old male patient who was brought in by the paramedics with a history of being involved in a motorbike accident. He had on his helmet and there was no loss of consciousness. The injuries that the patient sustained, he had a shed contusion with a suspected left pneumothorax, a query-pelvic fracture, and a left femur fracture. Patient received 2 liters of crystalloids pre-hospitally. On arrival, his vitals, blood pressure was 88/68 with a lab of 60, pulse rate of 120, and he had SAS of 90% on room A, and they went up to 94 in a non-rebreather mask. On his venous blood gas, you see that your patient is quite acidotic with a pH of 7.025, base excess of -8 by CARD 15. His lactate is 6 with a calcium of 0.89. So where do you start with this patient? So ensure that your environment is quite warm to the patient. If there's any air conditioner, switch off your air conditioners. Make sure you've got warm fluids in your, remove any wet clothes from the patient. Warm your patient with warm blankets or a new generation door header. Your patient has already received 2 liters of crystalloids. So you want to put colloids, which is our blood products, early on as possible. So now we want to work out the shock index for the patient. Okay, so remember the shock index is a heart rate over systolic blood pressure. Our patient's blood pulse was 120/88. So he falls at 1.4. So the normal value for the shock index is 0.5 to 0.7. That's where we want our patient. Mild shock would be more than 0.7 to 1. Moderate is 1 to 1.5, and more than 1.5 is severe shock. So we need to do a properly guided resuscitation for our patient. So at this point, our patient falls within the moderate shock. Tranexamic acid. This one, we give it early on. So what wakes us up with regards to the tranexamic acid is the CRASH-2 trial. It has shown that it reduces the need for blood transfusion, but you need to give it early on within 3 hours from the time of injury. So it's 1 gram IV over 10 minutes, then followed by another 1 gram over 8 hours. And where we lack the most is the second dose, where we don't give the 1 gram over 8 hours, because most of the time the patient then is transferred to the specialty or response theater. Early blood transfusion. With this, make sure that your blood is warm. Use a blood warmer. Do not give your blood as a stat dose. And remember the calcium, the 2 gram after every second unit of your blood product. And your patient not only bleeds water, they only bleed blood products as well. So remember your FFPs and your platelet. I'm not sure with regards to your massive transfusion protocol, but we usually use a 1:1:1, where we give 1 unit of platelet cell, 1 unit of FFP, 1 liter of platelets. Involve your surgeon and your trauma surgeon and remember the basics. Your patient has got chest contusion and pneumothorax, which can also precipitate to the hypertension that he's experiencing. So put in the IC drain. The patient has got a pelvic fracture, so bind the pelvis to obtain hemostasis. The femur fracture, that's where your patient can also bleed from there as well. So your track 3 binder or your skin traction with weights. The EFAST to assess if there's any intra-abdominal bleeding, and then your urinary catheter to assess the fluid output. And only send your patient for pen scan if hemodynamically stable. Those are my references.
Thank you so much. I just want to go back to your massive transfusion protocol. I think in my understanding that you're supposed to use 4:1. Usually 4 red cells, 2 FFPs, and 1 platelets. If you have a massive obviously transfusion, as rather to 1:1:1, because that obviously I think you increase her global state of patients. I don't know what size it is.
It's still 4:1.
Yeah.
But our platelets are mega platelets. So 1 pack of platelet equals 4.
Yeah.
So it is actually 1:1:1. But just the way we or the blood bank give our platelets, it's 4. It's a mega platelet.
It's a mega.
So it counts as 4. So the protocol is 4:1.
4:1.
4 red bloods, 4 FFP, 1 platelet.
It's not what we were talking.
No. Now it's 4:1.
Yeah.
I mean, we have 4 red cells, 2 FFPs, and 1 mega platelet.
In trauma world, it's very standard these days for one for one. Well, if you go
Because they equivalent, yeah.
yeah,
So many sources will say 111.
yeah. So our 441 is 111. It's just the way our platelets is back.
Yeah.
Yeah, and then the most important also thing about the hypocalcemia, which I think probably is one of the electrolytes that is really being misunderstood and also been overlooked in terms of the resuscitations. Not only in trauma alone, but also you see that mostly in the critical care, where the medical cardiac patients. And yes, I'm not so sure based on the US studies whether you can correlate the corrected calcium, or rather you prepare to have ionizing calcium, because ionizing calcium might take longer to obtain, because as compared to the corrected calcium, and if that's normal, is there any value a kind of increase in calcium to a certain level?
Look, with the blood gas that we have, it gives us the ionized calcium. So then they say with the ionized calcium, then you need to improve or increase your calcium level to at least 1.2 to 1.5 milligrams per liter. So because the blood gas is readily available, so rather we use the ionized calcium and the corrected calcium.
What about the factors that affected your ionizing calcium, like your pH? Is the pH affecting your calcium shift? I think yes. And then obviously, how do you then look at the patient that are hyperventilating or having pain, so they need to be more alkalotic, or those with high lactate levels tend to be more acidotic? Would that still?
It still does.
I'm just throwing the spine on the cable back. Bianca?
What I would do is I would consult with the trauma surgeon as soon as possible and get to the ICU so that you can manage that. I have an hour, and I can see with the arterial or venous blood gas. I can see if I have a trend. If I have an acidotic patient already with a low calcium on my blood gas, I know this is something I have to look at. But I'm not going to give him 6 grams or 10 grams that because I want what's happening in an hour. We can start with 2 grams. Then you can evaluate. When you redo your venous blood gas, then you see your trend going up, staying the same, going down. And then you can adjust from there. Giving large doses of medications because you suspect something is wrong is not scientific. Let's start with your baseline, and from there on, applying your mind to all the different aspects, see what you want, and you want it to go higher. So if you see you redo your calcium levels on the blood gas, whatever changes there, you need to adjust then your medication to that. Just giving medicine because we think in 8 hours something's going to be worse. That's not scientific.
But I think the beauty about calcium and magnesium is that lower cause harm as compared to higher. So there's no harm actually for you to give them calcium at the beginning. You have to get high levels. You're still very safe. But low calcium can be detrimental, the same as low magnesium. So I think, yes, on that aspect, I think on resuscitation should be extra part of a protocol to make sure you give them and then check. Yeah, because it's no one would come down. But
the formula that you can use to adjust the pH for the calcium, because we know that the pH goes down, the calcium goes up,
yes,
vice versa.
Mm-hmm.
So there is a formula to calculate.
Yeah.
That's very important. Yeah.
Slide. Where you give the calcium doses. I think it was for the. Yes, there. Because yeah, I'm not used to the grams. I know 10 moles, 10%. So it's 30 moles of 10% or 10 moles of calcium.
30 moles, that's 3. I think it's 3 amps.
3 amps.
Yeah.
Is there any role of sodium bicarbonate?
It's a good question.
Because if I see a pH of 7.0, 6.9, I might want to give a bullet.
In trauma, our first go-to is not sodium. In trauma, we first try to find your other circumstances that you can correct for it. Because our biggest danger in trauma is not necessarily to give the sodium. Our biggest problem is to correct the blood loss and the causes of the acidosis.
Yes.
So our focus is definitely not primarily on the sodium. You'll also hear when a trauma doctor phones you,
and you say, give Cytobic, they will start with, or, because it's not one of the first of our go-tos. Our go-to is
That's the same DKAs as
Yeah.
well. So
Yeah.
it's fluid.
we go first,
I think,
correct the fluid.
no, I think you need to answer this question technically. It depends on your pH. Now, if your pH is below 7, let's say 6.8, then this roll back up to improve your pH to 7, because that actually improves your hemodynamics.
And the
Because
way
your
the
blood
medication.
pressure
Right,
and drop.
fine, kind of.
But if a pH above 7, perhaps there's no role. But also you have to, under trauma, the assumption will be that if a pH is low, that will be because of low lactate, because high lactate level.
Yeah,
And
so
then
just
you're
that.
absolutely right. So that means the resuscitation there will be based on the fluid. In this case, in trauma, I don't know what fluid you use, but I think normally, I remember when we did a study before, where actually you better off with crystalloid than the colloids.
Yes.
And obviously you need to give them your crystalloid and maybe as agent as blood product as much as you can, and try to get that to increase your oxygen carrying capacity. So I think yes, Leanne, they said well for back up in the case setting that the pH is very low, and then you can be able to back up. But the aim is not to just maintain even above 7, but not above 7.3.
It's not going to help if you
Yeah.
don't address the underlying
Yes.
cause.
Yeah.
We have the
so-
main focus first, and then we move on to that once we see with our follow-ups that we are not.
It's the same thing as glucose. Glucose is very important. Make sure glucose above 3.5, and the list goes endlessly. But I think if you once you address type A like lactic acidosis, then your problems are really addressed, I think. But resuscitation can be really a very big problems, especially on in case of levels if you don't have, and that's why this for emergency casualty of physicians, you have to have certain kind of routines where you act, where you could say you need to be able to practice go from A, B, C, D. And that's the reason for that. You cannot jump from A to D, because the moment that you start jumping around, you cause more harm. So you kind of have to keep the routine. And I think that's most people don't understand that, because your brain functions through routines. And that's what actually get a very, very good result. So we have one where a guy actually had a MBA with a cardiac contusion, and then we immediately, there was a bit of cardiac was called, and pulmonologist, and out of blue now, I don't say patient must go to theater, but patient got pH 6.8, patient need to be intubated. Angiogram. I mean, the other day,
It's not the most primary adjunct or secondary.
exactly. So you cannot
Way
need to
down.
make sure resuscitate, intubate your patient, stabilize, giving fluid and everything. Because the angiogram might not actually change your outcome of the patient, because the fact that the patient is not dead is unlikely to die. So you kind of need to correct what's correctable. That
From MI.
yeah, from MI, exactly. So I think it's always it's very important. I think that the routine, especially for the junior casualty officers, is always very important too.
Even for the seniors, if I skip one thing, I know it's the one thing I'm gonna.
Yeah.
You
But
go through
also
that.
remember, when you skip one thing, your brain become confused. You can't think of anything better anymore. The brain takes you back to what you escaped. And really, for me, it's a waste. And I think that's probably that's how the training should be. Get your steps right. And if your steps are right, it's easy for you to see beyond your step and start looking at calcium and other stuff. But if you haven't protect your airway and the patient gasping, now you want to correct calcium. Not going to help you.
Well, in that same manner, I mean, so big, if you got a patient that's a multi-trauma with every patient, CO2 is fine. The worst thing that you can do is give.
Give
Backup.
more.
So they need to start literally with ABCs. Now, once before you haven't corrected the PCO2, then that's, you're going to kill the patient. If you get to surgery.
Yes.
That's why I stick to ABC. So I always say the best is for everybody else. Learn how to do step ABCD and just skip everything.
It's like Walter Klucker has this saying. He says when you like doing resuscitation, or managing a critical patient is like a chef baking a cake. So there's a recipe that you use, and you use that recipe meticulously. Only once you're very experienced in some circumstances can you start to vary on this the recipe depending on the outcome that you want. But for starters, certainly for junior doctors, you stick to that recipe.
But remember, you can only test the recipe being wrong once you know A, B, C, D to D.
Yes.
Yeah,
And I think we have seen it in our ICU because we use a lot of hard care and in terms of their labs. And we have always seen from old results the end where you get the latest results. Now, the moment you get different lab like Lancet, now it's the other way around.
Yeah.
People get thrown off completely. You miss basic stuff. And because your brain out of blue, because that's the way you always have to look at the results, not out of blue, you must do the opposite. And you miss a lot of stuff. And there's something here applied to resuscitation. And doctors need to do that. The question that I always say, if you're too intelligent doctor, then you must actually retire. You don't
Should
belong
do
there.
what?
If you're too intelligent, you need to quit. Because the question that there's certain things in medicine does not require intelligence. It requires basic principles. Okay, and if you can do the basic principles properly, A, B, C, D, you'll be better off than somebody who looks at, oh, I know everything. And when that moment finds you, you actually mess up. And we see that.
We are humbled daily in
Yes.
casualties, every single day.
And that's why you need to kind of go backward and learn. Online, anybody there? Oh, you got even audience. Welcome, guys. Thank you for joining us despite the late advertisement. Any questions?
Just the one thing I want to mention as well is that the resuscitation base is notoriously cold. So the temperature is set on low for infection control. Even the doctors become hypothermic. So
Yes.
just imagine your patients. Like, it comes from this whole thing of ACLS at one stage, like cardiac arrest should be hypothermic or relatively hypothermic. But normal patients, just the opposite. You expose them, and it's so amazing that by the time you finish your primary survey, your life-saving procedures, the patient has been exposed for a while. Then you've got a cold aircon blowing on top of you.
Yeah. What's the temperature actually in ED? Because I think Leanne was asking me
Standard 21.
Yeah.
21 degrees because our ICU is sitting at 23 degrees.
There. So
For me, even double hot, you could imagine.
The one that's mostly the aircon's not working, it's probably warmer, like 5 and 6. Aircon isn't big enough for the area, but most casualties 21.
Yeah, it is set at 21, but close to a door or close to an open place, those temperatures vary, but your standard, industry standard,
should be
something like
21.
21 to 22, and then basically they set it at 21,
Yeah,
25.
so it's not yet.
And then in resuscitation, what about on the thing, the warming of blood? How practical is that?
You've got the blood warmer. Yeah.
Okay, so you
You've
can
got the administration set with the warmer in, and then you warm it with cold in the back through the pipe. You've got the warmer going with the inside workplace to the patient.
Cell besides aerosols? Besides the whole blood?
Whole blood or
Yeah, whole blood besides red cells. What does the literature say in resuscitation?
Ideally, they say whole blood.
Because if you go to countries like Sudan, Malawi, where they don't actually have a lot of storage, you find that a family comes in, then they just donate blood to the loved ones from here to there with all whatever is there.
Well, that's really whole blood.
Exactly, it is.
Okay.
I remember that. It's crazy.
I've seen that in my life once.
but you're gonna use what's in your emergency. That's in your
I
We got
will
whole
I'll get my whole, but if I don't,
Even if the patient has got a massive hemo to transfuse from the.
that's intercostal drain. Yeah. They bring in the intercostal drain. And as your patient bleeds out, if you don't have access to blood, then you just got to transfuse. You do it in PS as well.
Okay. theatre, there's a thing called soul savers.
That's
Same thing.
It's not that's there's auto transfer.
You make it sound very dramatic.
It is very don't have something.
dramatic, that element drama.
Do you think a trauma unit is not dramatic? It's a drama.
Very exciting.
Yeah, it's yeah, but I think medicine is really interesting. Yeah, I think my experience, of course, with the trauma was in California with Louis Engelberg. It was quite a very good experience. Yeah, she was very lovely, I must say. Quite a very good mentor. Yeah, that's when I slightly fell in love with the emergency medicine. You could just get things sorted immediately. If you got a very good efficient system with good nursing and a good way to go, even like the orthopedic injuries, you don't even need an orthopedic immediately because you could reduce some of the fractures on the side, put them on the stabilizer, and for me it was quite amazing. You could actually do so much, but you have to be going. So casualty does not require people who walk into people that are very extremely efficient. It's crazy actually.
Any questions out there? Nothing.
Okay, I think the next
Okay.